Thank you everyone for being with us and being in this call conference for today. As you know, we invited Dr. Stefano Aliberti, Director for COVID Registry High Dependency Unit at Policlinico Hospital in Milan and Professor of Respiratory Medicine at the University of Milan, Italy. And I really appreciate Stefano for being with us and taking time and talking with us on COVID-19 condition in Italy. Anyone can see Stefano?
Yes, we can.
All right, excellent. So Stefano, please a little bit share your experience about epidemiology of COVID-19. That's gonna be first part of our talk today. And let us know that what is happening at this point in Italy.
Okay, so thank you so much, Mehdi, for this invitation. It's a pleasure to share some experience with you with the US there. I hope you guys are fine and you're not seeing a lot of COVID patients as we are doing here in Italy. So Dr. Mirsaeidi asked me to give a general overview on the epidemiology of the situation in Italy. And I think that the best would be to just to tell you the story so that you will able not to do our mistakes, because this is the major issue. So one of the major challenges we had is that we were not prepared at all. Although we were a Western European country, although we believe that our healthcare system is good, the point is that the COVID
on exit
in terms of healthcare professionals contacts. So when the first case came in Italy, and this was mid-February, at the end of February, actually we realized that the coronavirus was in our country at least since 3 to 4 weeks before. The point is that we underestimated, first of all, the protection between healthcare workers. So we started to implement our procedures of having a face mask and all the different procedures within the hospital. Just when the first case of coronavirus came in the country. And a lot of physicians got infected. And at some point at the beginning, we had in our hospital more physicians infected than people in the ICU. So this is the first point. So I see, for example, Dr. Mirsaeidi not wearing the face mask with people less than 1 meter far from him. So this is something that I would not suggest. So from now on, as soon as the first COVID patient is in your country, all the healthcare professionals during the meeting, during any kind of contact within the hospital, also in front of a coffee machine, should wear the face mask. So this is the first point. So we started to implement these procedures too late. And once the healthcare professionals is infected, this means that for the next 2 to 3 weeks, this colleague is not supposed to come back to work, because we have some procedures. You are supposed to have the nasal swab negative twice, so it takes a lot. So although a lot of our colleagues were clinically cured, they were not microbiological cured. So they were still positive on nasal swab after 2 weeks. So they were not able to come to work. And this is very important because then the resources are very limited. So then you need to be prepared to move all the meetings, all the communication within the hospital with web-based, to reduce all the face-to-face meeting from now on, and try to avoid any kind of contact between physicians. We are more protected when we are working in the COVID ward than when you are working in the hospital. So this is the first message.
All right, great. Thank you, Stefano, about this. Please a little bit talk to us regarding what your protocols are, who you're gonna do test, what type of test you do, and then who's supposed to be admitted in the hospital.
So these kind of procedures changed a lot according to our resources. So at the beginning when we had 100, 200, 500, 600 patients, we had some procedures, but now on we have 20,000 people infected, more than 20,000 people infected. The procedures are really, really different. Still, we all believe that the identification of the patient infected, the control of people who got in contact with him, the quarantine, the isolation of all the different contacts is a very important measure to reduce the number of people infected. So at the end of the story, we are not talking about to reduce the number of people infected, because at the end of the story, we will not be able to do that. What we are talking about is to reduce the timing of infection in order to have more ICU beds to treat our patients. So in order to decrease the curve and have all these patients treated not in a short period of time of 3 months, but in a longer period of time of 1 year, 2 years, in order to do not push too much on our healthcare systems. In order to do that, we decided to change our procedures. So if the patient has a clinical, the patient is clinically COVID positive, and the patient can stay home, we can monitor the patients in terms of clinical status. And only if the clinical status is going down, the patient is going to the emergency room, having the nasal swab, and then making the diagnosis of COVID. So this is what we are doing now, at least in my county. And the reason why is because while I'm talking to you, while I'm talking to you, we have more than 350 COVID patients in my hospital, with 4 COVID ICU, with 4 COVID high dependence unit, and with 4 low dependence unit, COVID low dependence unit in my hospital. So we started having 1 pneumonia, the day after 5, the day after 20, the day after 50, the day after 100, the day after 200 pneumonia COVID positive cases in my hospital. So we started to rearrange all the hospital, to build up walls, and to change the structure of our hospital. And I think that in 2 weeks, all my hospital will be a COVID hospital.
I see. So please share your experience with isolation. How you isolate patients? How is possible whenever you have huge number of patients?
So the situation is this one. So the patient is coming to the emergency room with a clinical suspicion of COVID. So we have we build up tents in front of the emergency room in order not to have people COVID positive coming in the emergency room. In this kind of tents, we do the triage, and then after this triage, the patients follow different pathways. For those who are critically ill, without a definitive diagnosis, we have just one ward. So we identified one ward of people who are waiting for the microbiological results. So these people are under intensive care or medium care, waiting for the results in a specific COVID ward. Then at that point, then we divide. Then if they are COVID negative, they are admitted to COVID-free department. If they are COVID positive, they are admitted to COVID department. And for example, I'm directing two high dependence unit, two COVID high dependence unit, and we work. And our way to work is a cohort way. So we don't have single room. So when you enter the ward with 50 beds, you enter a COVID area. So we don't isolate people because we all are infected. All the materials in the ward is infected. Everything in the red in this red area is infected. And all the high dependence units in my hospital work in this way.
I see.
So there are pro and cons. The pro is that we reduce the number of DPI. So this is very important. We reduce the number of DPI. Otherwise, we are running out of mask and coat and whatever. There are several cons, but this is the way we decided to work. We don't have a single room for isolation, negative pressure, stuff like that. I mean, some of these high dependence unit ward are supposed to be negative pressure, but not all of them.
Okay, so for those patients that PCR back negative, what is your maybe accuracy rate that is really negative and the patient is not positive at all?
So this is a very important point. So we don't believe a negative nasal swab in a patient with a CT scan and the clinical highly suspicion for COVID. So we implemented the procedures. So So let me tell you this. Most of the surgery decreased because they are not doing surgery because of the COVID situation. So we identified thoracic surgeons as those who are doing bronchoscopy in patients with negative swab who are highly suspected for COVID. So for those patients with a clear CT scan, with a clear CT scan and with a clinical suspicion of COVID who are nasal swab negative, we are doing bronchoscopy in order to find out they are positive. And this is important from a public health perspective, but also to allocate the right patient in the right ward.
I see. So in that case, you have three groups. One, confirm COVID-19 that gonna go specific floors. Second group that they are suspected, but PCR is negative. And third group that you think that very unlikely to be COVID-19. I understand that. So a little bit share your experience regarding treatment. How you gonna start antiviral, what antiviral you prescribe over there in Italy, and what about other medications?
So we stratify according to severity. We stratify according to the presence of pneumonia, age, comorbidities, and severity of disease. These are the four major criteria we use to decide to start an antiviral treatment. for all the patients in my unit, all the patients in my unit have a COVID pneumonia. They are under non-invasive ventilation or non-invasive CPAP, all of them. So for these patients, all of them are receiving antiviral treatment, off-label antiviral treatment with Caletra and hydroxychloroquine. Okay, all of them. We are now thinking to not giving this to DNI, DNR patients, but this is a very long story because our criteria for DNI, DNR are changing every day because of resources, mainly because of resources. So the latest procedures in my unit is to give lopinavir, ritonavir plus hydroxychloroquine for all the patients, regardless age and regardless DNI, DNR status. But I'm not sure that these criteria will be applied for the next few weeks.
Okay, and then how many days do you continue your antiviral in those patients?
Yes, so the story is that the treatment is between 5 and 20 days according to the clinical situation. So at least 5-7 days for those with mild disease, 2 weeks for patient on non-invasive ventilation, CPAP, no, I'm sorry, not at least 2 weeks. Maximum 2 weeks for those on non-invasive ventilation and CPAP, and maximum 20 days for those on for those who are intubated. But for those who are intubated, for those under mechanical ventilation, we give as a first line another antiviral treatment with remdesivir on compassionate use as antiviral treatment. But what we are implementing now is not antiviral treatment, but is anti-interleukin 1 and anti-interleukin 6 treatment. So these are the kind of treatment we are implementing in our patients, and especially in those with a high level of interleukin 6 in serum and with high level of ferritin in serum.
I see. And what is your experience regarding those anti-IL-6 patients? Have you had any of those, and what is the response?
We have very few patients, Mehdi. The point is that interleukin 6 is a little bit tricky because the half-life is pretty long, 4 weeks, 1 month. So this means that we cannot control the drug too much, while anti-interleukin 1 has a half-life very, very short. So in case of super infections or any kind of complication, we can stop the treatment very, very, very easy. So now we are more into this anti-interleukin 1 treatment rather than interleukin 6.
Great, great. You talk about remdesivir. A little bit share about remdesivir experience with us.
So, Mehdi, my experience with remdesivir is very limited because I don't see intubated patients. Because the intubated patients are seen in the ICU. As you know, guys, in Italy we are 2 different people. There are pulmonologists and ICU physicians. So this is something that I mean, I know something from the literature, but I can't share any clinical experience about that.
Okay, great. The last question that I have, and I'm gonna open for other people to ask questions, is when do you discharge a patient? Do you test it for PCR or you clinically just discharge them?
Yeah. So the situation is we have the clinical cure. So when the patient is clinically cured, we have a system where we organize the discharge at home in a safe conditions. Mm-hmm. So if the patient can go home in one single room with one bathroom with the face mask and blah, 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 so we can discharge a patient at home, and then our ID physicians will take care of that and will follow the patient until the nasal swab is negative 2 times, twice. Then we have a big hospital in Milan that has been built up only for those who are discharged from the hospital and they cannot go home in a safe condition. So we had a military-based hospital for those people who maybe they are discharged with a 2-liter oxygen or 3 liters nasal cannula oxygen. So they go there as a very low intensity kind of cure for 10 days, 2 weeks, and then they are follow up for microbiological cure.
Okay, great. So at this point, I want to open for question for other people that they are here, and then we're gonna back to you with some question. Looks like that I have some question written here, actually a lot. But the last one is talk about ACE and ARB. Do you want to have any comments on this? That what about people on hypertension and using ACE and ARB medications? Are you concerned about that, or do you have any action? What you are doing in Italy?
So no, not in Italy. In my unit, Mehdi, because this is a very heterogeneous kind. So
hey, Blasi, how are you doing? Very good to see you, Blasi, here.
So this is a surprise for you.
Yeah, it's great.
So I want just to have also Professor Blasi on this call. So I'm really happy that he was able to join the call.
That's great.
So this I need to put my face mask now.
Yeah, I need to do it too then. So thank you, Dr. Blasi, joining us. And we are here, I guess, more than at this point. We have 70 or 80 people around, and they are learning about your experience about COVID-19. And Stefano actually did excellent job, shared great information with us, and I really appreciate that. And I would be happy to hear, okay, more if you have anything concern. I guess that he does have a call conference or something.
So we don't have. So this is the last of our. So this is something that we are thinking about. This is something we are thinking about, but we don't have very strong data. We are doing a study about that. So we are taking blood from our COVID patients in order to better understand this the role of this medication and this biological pathway. But we don't have a strong standard operating procedure about that.
Okay, so I have another question here for you, Stefano, asking about timing. When you in CT scan you see fibrosis atelectasis in the COVID-19 patients.
So listen, CT scan. So let me tell you what is the typical patient of my unit, so you can better ask me question, because otherwise I will not able to answer this. So I admit patients with a PAFI ratio between 100 and 150, with a pneumonia, usually on helmet CPAP, under 12.5, 15 centimeters of water as a pressure, as a positive pressure, and a FiO2 of 50-60%. So this is the typical around 60 year of age, with maybe just one comorbidity or maybe two comorbidities. So this is the typical patient we are admitted in the COVID high dependence unit. So in these patients, we are not doing CT scan, okay? Because we don't need a CT scan. We do lung ultrasound, and we see consolidations on lung ultrasound as a bad prognostic marker. So we see all the B line of the interstitial pneumonia. We follow the B line we use the beeline in order to better put the PEEP for our the pressure of our non-invasive ventilation. And then if we see consolidation, this is a bad prognostic marker. So we don't need to do CT scan because we don't waste. There are some logistical issues to make a patient going out from a COVID unit and then coming back. The CT scan, we did a CT scan if there is a complication like a pneumothorax or pneumomediastinum or stuff like that. But for this kind of people, we just do lung ultrasound. Then when the people are intubated, then before going to the ICU, maybe we do a CT scan before entering the ICU.
I see. So I have another question for you, asking that about number of vent that is limited. How do you triage who should be on vent?
Vent means non-invasive ventilation or intubation?
Ask about intubation.
So do you want the truth? Do you want the truth or do you want a polite answer for that?
I think Italian way, I accept that.
So let me talk to my lawyer first. No, the situation, Mehdi, is evolving. So at the beginning, we were very open for intubation. At the end of the story, now the criteria for intubation changed a lot because we don't have beds for ICU. So we are not intubating maybe a 75-year-old man with a couple of comorbidities just because we have just one bed and we have another 45-year-old patient in the same situation. So this is the truth.
Yeah, I understand that.
We are opening a lot of ICU beds in our hospital. We are changing all the logistics situation in our hospital, adding beds and beds for ICU. The problem is that the number of patients is so high that we are never comply. We can't have enough beds for all the patients that need to be intubated. So at the end of the day, we have to choose the patient. That's the problem. For us, is a real issue.
I think that's going to happen to every country with a high number of COVID-19. I have a very good question, another one here for you. What is the rate of bacterial infection on top of COVID-19?
Very low, very low. So this is the super infection with a bacteria in COVID-19 is very low. So we decided, for example, to limit the microbiological test for COVID-19 pneumonia only in case the WBC is more than 10,000 or CRP is more than 5. So just in this case, we are doing blood cultures, urinary antigens, and other microbiological interventions. Otherwise, we are not doing anything for them.
I see. Can you just share information regarding what percentage of patients with COVID-19 been intubated in your center? How many of them you are using non-invasive and how many of them you have in the floor? Any estimation or rough number?
Yeah, the issue, Mehdi, here is that we are a country that is very pro for non-invasive ventilation. Okay, so we are very pro for non-invasive ventilation, non-invasive CPAP with helmet, stuff like maybe in the United States, the healthcare system is very different. So this is the first message. The second message is that non-invasive ventilation and non-invasive CPAP with helmet has a very high rate of failure. So the only reason why we are using this is just to gain 2 or 3 days in order to have the ICU bed free to have the patient intubated.
Yeah. I
So
totally understand that.
the message is intubation is the treatment. Intubation is the treatment. But in if the number of patients will be really high, so then the number of people who are on non-invasive ventilation will increase just to gain time for intubation.
Correct. I have 2 very important questions. Please answer kind of short for us this. What is the rates of influenza co-infection in the patient with COVID-19?
So now it's very low, Mehdi. Very, very low. At the beginning, we were able to see both of them, but at the beginning of the pandemic, not now. Now all the influenza nasal swab are negative and they are COVID positive.
So another question is regarding resource utilization. What PPE is being utilized for the COVID-19 suspected versus confirmed cases? Do you use, for example, N95 or you use surgical mask for the confirmed or suspected? What is your policy over there?
So, as you are aware, the WHO released a document 6 or 7 days ago saying that this mask I'm wearing is enough for COVID-19 patients. The point is that we as a pulmonologist, we are doing bronchoscopy, we are doing high flow nasal cannula treatment, so we are more exposed to droplets. So internally in our hospital, our general director allow us to use the FP3, FP2 mask in the management of these patients. But when we are in the clinic, in the pulmonary clinic for bronchiectasis, COPD, asthma, or whatever, we wear this mask and the patients are wearing the same mask.
I see. And what is the rate of recovery for patient that after intubation?
So the truth is, we intubated patients 3 weeks ago. The first patient intubated in Milan 3 weeks ago. All the patients but one are still under invasive mechanical ventilation. So we think that 2 to 3 weeks is needed for intubated patients.
So how do you handle the staff who may be exposed when they are always in front of these patients?
So nasal swab positive, COVID positive. So if a physician is COVID positive, this is your question.
Yes.
So if a physician starts having fever, respiratory symptoms, the physician goes home. That's it.
For how long?
So then if the physician is developing dyspnea or shortness of breath, then he comes back to the hospital. He's doing nasal swab. And if the nasal swab is positive for COVID, then we triage the physician and maybe can go back home and stay home under the care of the regional healthcare systems, monitoring the clinical situation and until he is negative for nasal swab 2 times.
I see. Do you use any post-exposure prophylaxis for the physician that been exposed? No.
No.
Right. All right. So I think that thank you for your time. You did excellent job and I really appreciate that. We have a lot of more questions. I can email you. But the last question I want to ask is, do you have any tips regarding the condition that right now is going on here in the United States? And maybe in the next few weeks, we're going to have the same number of patients that you have at this point. Anything that's going to be useful for us to prevent more damage for these epidemics?
So stay at home. Stay at home.
Stay at home. Yeah. So yeah, first of all, preserve physicians, nurses, respiratory physiotherapists, preserve the healthcare professionals. So this is the first message, because this is so important. The second message is the treatment is intubation for most of these patients. So you need to be prepared from this point of view. If you need, but there are some patients that might, roughly 30% of patients are under non-invasive mechanical ventilation or non-invasive CPAP with helmet might respond. So this is a weapon. This is an important weapon you can have. And the most important thing to me in these first weeks of COVID is do not believe that your patient is improving, because the day after is getting intubated. So the concept of time to clinical stability we have in the strep pneumonia, in the pneumonia due to strep pneumonia or other bacteria you treat, actually doesn't work in COVID pneumonia. So the concept of timing to clinical stability and stuff like that doesn't work. These are mostly non-resolving pneumonia with an up and down situation. And then in 6 to 8 hours, they are going down and they are getting intubated.
Wow. Yeah. Thank you, both of you, for your time. I think that was very great and important experience that you share with us. Please keep us updated. We really like to hear from you and learning from you. Whatever that you are doing is really a good guide for us here. And I'm gonna send a lot of questions that I'm receiving right now. Probably I can email to you and we can communicate with people via email.
Okay.
At the last word for us.
Bye.
Okay, bye-bye.
All right. Thank you very much. I appreciate it. Thank you. Stop video.